Good morning and welcome everyone. I'm Sarah Walno, I'm the Chief Executive of the King's Fund. Delighted to be here this morning to host the event on the review of the UK's data landscape. We're going to hear from Cathie shortly. Before that, we're going to hear from the commissioners of the review, and then we're going to have hopefully a lively discussion and a Q&A session, which will give people the opportunity to explore some of the review's recommendations in a little more detail. Right, sorry, we do, here we go. Oh goodness, it's jumped ahead a little. I've got housekeeping notices, there we are. So no fire drill planned is the key message, and I'll leave you to read the rest of them. The only other thing I want to say is, for the majority of my career before joining the King's Fund, I've worked in medical research charities and health charities, and I have seen firsthand both the power of health data to transform research and to change people's lives, but also some of the challenges and the frustrations and the slowness where we struggle to link data in a timely fashion, and the impediments to patient care. So this review is timely, it's important. I know it's been a lot of hard work, and we look forward to hearing the contents about the contents in more detail. With that, I'm delighted to welcome to the stage Professor Chris Whitty, CMO, who was one of the people that commissioned the review. Chris.
Thanks, Sarah. I really just wanted to firstly start off by thanking all of you for coming to engage with this. Very much thank HDR UK, who've done so much to support this, and above all thank Cathie Sudlow for doing the report, which I know has been a lot of work. It is, I think it's an excellent report and will be extremely helpful to all of us trying to move this area forward. I'm going to make some slightly obvious points, which we treat obvious to everyone in this room, but don't sometimes get lost, I think. I mean, the first is there are multiple uses for data, and they include, for patients now, where we very often have people who would benefit from having their data brought together for their current treatment, and we're not currently able to do that for technical and other reasons. It's important for the NHS to be made more efficient and more effective, and indeed wider health services, where you can actually get significantly better outcomes if we could actually use the data in a much more effective way, as any large organisation ideally would be able to do this. The NHS in that sense is not unique. This is a general point. And the third is the benefit for patients in the future that are brought about by data being able to be brought together for good patient outcomes. And all of these are reasons why data can be enormously powerful for patients now and for patients in future times. So the second point in general on that is the gap between what we can do with data and what we are doing with data is actually widening. And that is because the number of data sources that are potentially usable, the number of techniques we've got, the analytical techniques we've got are steadily improving, and yet our ability to bring data together has not improved at anywhere near that rate. So the barrier now is largely artificial between where we could be and where we are today, and that is only going to get larger unless we do something about it. It was for that reason that the NHS, ONS and the chief medical officers came together to ask Cathie to do this review, because we see this as an area where we could do a lot better than we are at the moment, and that will be enormously beneficial to people if we can achieve that. Finally, I just wanted to make some points about why have we not made progress to date. And there are lots of reasons for those, but I would really highlight two in particular. And I say this because I've been involved peripherally in this area. Many of you have been involved much more fully for well over a decade, in which time everybody's agreed we need to bring data together, and yet it has not happened. Two barriers in particular I think we need to be very aware of. The first of which is we must continually engage with the public and with patients and make sure that their needs are the principal reason we're doing it, and that they understand that and that they can contribute to that. And I think some of the things we've had, and I'm unfairly going to pull out care.data, I think fell over because we failed to make sure we were alongside where patients and the public wanted to be. The second, and I'm going to be slightly more hard-edged about this, is that people can be quite selfish about this in the various communities. People who own data often want to hold on to it. People who want to see systems wish to optimize the system for bringing data together for their particular uses and have not really cared much about other people being able to use the data as well. Any system has got to be able to be used for the multiple ways in which it can benefit patients rather than just for a particular use for a particular organisation. And it is frankly unethical, in my view, for people who own data not to be prepared to share it when the clear benefit is going to be to patients and the public. And I think that should be called out and called out fairly firmly. Finally, I'd really just like to finish where I started. This has been a lot of work to get to this, but I think this is an excellent report, and I'm really looking forward to the discussion we're about to have. So thank you all very much, and I think it's over to Vin.
Thank you, Chris. So for those who don't know me, my name's Vin de Walker. I'm the National Director for Transformation in NHS England. I'm a paediatrician by background, used to work in Birmingham and at Great Ormond Street. I am genuinely really excited by this report and really excited that Cathie is here today to launch it. I think it is a significant call to action for us in the NHS in England and for our colleagues in the four nations. It's a significant call to action for all of our partners in industry, for partners in government, and for partners in other organisations in academia and elsewhere. We know, for all the reasons that Chris has stated, that data saves lives. I think the government has set out a really compelling set of missions about reducing the deaths from the biggest killers, increasing healthy life expectancy, and making Britain a fairer place to work. And I know all of us who work in health or care, actually that's something we can really get behind and galvanise behind. But none of that is going to be possible without data for all its different uses, and none of it is going to be possible without research. And I think the report that Cathie's written recognises the unique opportunity that we have in the UK compared to the rest of the world, firstly to leverage the benefits of living in this fantastic, diverse society that we live in the UK. The second is to leverage the benefits of having a health system that is free at the point of access, available to all, funded by general taxation, linked together by a single identifier. And there are very few, if any, health systems in the world who care for such a diverse population under those circumstances. And we owe a duty to ourselves, to our population in this country, but also we owe a duty, I think, to the world in terms of our understanding of disease to create data assets that meet that big challenge. So Cathie quite rightly points out the complexity of this very complex data environment. And in fact, bringing all those together is not going to be easy. We haven't been sitting on our hands, and Cathie acknowledges that in the report. I'm particularly as an NHS England director delighted to see that she acknowledges the work done by our secure data environments across the country. We brought together local communities, local government, the local NHS, local leaders to create secure data environments that currently are looking after over 500 research studies and have got 30 million GP records in them based on local trusting relationships. But we don't have the National Data Research Service that Cathie calls out in one of her most eye-catching recommendations. Now, we have already started work on this. Both myself as the responsible National Director for the NHS in England and Professor Lucy Chappell, the Chief Exec of NIHR and a Director General in the Department of Health, have convened a group, and over recent months we've taken what we knew of the early drafts of Cathie's report and already started working up a plan for how we could make this happen. And we have started talking to ministers and government about the importance of this as critical infrastructure for the success of the UK. So we're delighted, I think, to introduce Cathie. I think Cathie's called out the need to be ambitious. We agree. The need to be bold. We agree. And we are building our proposals already. We are working with the public. So with Nicola from Understanding Patient Data, I was in Leicester last week, live streaming to citizens' juries across the country, talking about the valuable use of data to make sure that we work with citizens, we take into account what they say, and we create trust in the ways in which research can benefit them and benefit their communities. But if we get this right, over a period of years. I think we've got genuinely an opportunity to take where the NHS and where healthcare is currently now and genuinely turn it into an NHS that is personalised, that is integrated, that is digitally enabled, that is data-driven, and one in which science and technology and research can genuinely enhance our lives and the lives of our communities. And I think that is a very exciting place to be. So I'm going to introduce the lady of the moment, Professor Cathie Sudlow. She's one of, as many of you know, our leading clinician data scientists, a practicing clinician in Scotland. And I think I can't think of anyone better to have led this report, which is why my predecessor, I, Chris and Ian commissioned her to write this report, and we look forward to hearing your findings, Cathie.
So thanks very much. I think Chris and Vin have kind of given you most of what you need to hear. So that's let me off the hook to a great extent. But anyway, thanks for the opportunity to tell you about this magnus opus, which has been in gestation for what Lucy Chappell reminded me is the period of gestation of an elephant rather than a human being. So it's been quite a long time coming. But I think this is very timely, actually, in terms of when this has actually landed. So what was I asked to do? I was asked to provide a comprehensive overview of the health and health-relevant data from across the 4 nations of the UK, and then to outline some of the key barriers to sharing or accessing those data for the benefit of patients and members of the public and society, whilst, of course, keeping it safe and secure, and to think about some of the solutions that need to be put in place to overcome those barriers. And for that second part, there was an ask to focus that part on England. I think partly in recognition that this was a monumental task to start with, and that the 4 nations of the UK are somewhat different. But at this stage, I think it's important to say that the principles behind all of my recommendations, and indeed the findings of the review, apply across every nation of the UK. Some of the specifics are a little different, and amongst my 5 recommendations, 2 of them are very much directed at all 4 nations of the UK, and the other 3, the principles are very similar. So, just to give you a brief flavour of the various health-relevant data that I've dealt with in some detail in a central chapter in the review, which you will only want to read if you're particularly interested in some of these. But there are many different sources of data that are relevant to our health. Many of them, of course, come from the health and care system. Every time we visit our GP, every time we go to hospital, every time we have a scan, health data is generated about us. And across the 4 nations of the UK, some of those data are already brought together into national collections of data that provide really helpful, albeit quite not particularly detailed information, but really helpful information about, for example, diagnoses made in hospital, the fact that a scan happened at a particular place at a particular time, and increasingly also information from general practice has started to be pulled together at entire population-wide national scale. And increasingly, and we saw this move forward at great pace during the pandemic, because there was a really good impetus to make it happen, these data are brought together in national secure data environments, and there is now that capability in each of the countries of the UK. Before the pandemic, it really wasn't so mature in England. It's a big country, and it was really important to get that in place, and I'm very pleased to say that that is now in place, and lots of other wonderful developments are happening in its wake. So we have this network of secure data environments around the UK that now hold this data securely, and researchers and analysts can access these data remotely and work with them to generate insights without having any of the personal identities of the individuals whose data are represented revealed to them. There are also data that are held and kept regionally or locally, and those tend to be the much more granular and complex data from the free text, all the text in medical records, or from images that are very complex data. And those are much more difficult to sort out, to derive structured value from, and to move around. And so they tend to be held in smaller repositories, and rightly so. But it's really important to be able to create a national picture from them for a range of purposes. And then there are data relevant to our health that come from way outside the health system. So data from other government departments such as education are really important, because we know that children's educational opportunities are likely to have an impact on their later life health, and some of that has been demonstrated. But there's so much more we can do to understand exactly how that works, and to do it in a way that helps us to inform healthcare policy and public health policy and other wider policies in the future. And then there are data from outside of these administrative systems, from our own personal monitoring, wearables and apps and so on, generating data relevant to health, data from on air pollution and weather that are relevant to our health, and importantly, data generated by large research programs and large research studies. And I've shown a few examples here, like the UK Biobank, as many of you would have heard of it, but also big trials like the Recovery Trial, which ran during the pandemic. And the key point is that all of these different sources together in isolation are quite helpful. They tell us something, but it's when they are linked together that we really start to be able to generate transformational insights. And I'm going to just show you a few examples. So, as I said, during the course of the pandemic, it became possible to link together data from different sources across each of the 4 nations of the UK within secure settings, and to interrogate them for answers to questions that were incredibly important during the pandemic. So, for example, it became possible to study who was being vaccinated, what the rates of vaccination were, not just at national level across the 4 nations of the UK, but also in subsections of society by age, by ethnic group, and by other characteristics. This is only possible because data from general practices, data from hospitals, data from infections laboratory data, and data on vaccination data could be linked together. And that made it possible to address some of these key questions about what characteristics made one more likely to not be optimally vaccinated, and how that impacted the risk of developing severe COVID infection in the future, for example, and clearly very important for informing policy. There are also some really great examples of those more granular, detailed sources of data that I told you about, but tend to be brought together where it's possible to, in smaller population segments, as it were. And one example is from Scotland, where data from all the NHS Scotland images have been brought together going back over about 10 or 15 years, and made available within a secure setting, linked and linkable to other sources of data about our health in the future. That means it's possible to use a resource like this to interrogate what features of imaging, controlling for other factors, might help to predict, for example, the development of neurodegenerative conditions like dementia in the future. And it's only possible because we've got all this data going back in time, as well as data going forward in time about the health outcomes coming from different parts of the system. So linking together these whole population healthcare data and data relevant to our health is done through these secure environments. And there's an important role as well for the Office for National Statistics here, which of course holds and makes available securely data from a range of these other sectors of society, in some instances across the whole of the UK, and in many instances for England or England and Wales together. And there's a great opportunity using this network of secure data environments to start to really properly interrogate the relationships between data that comes from the health system and data that's relevant to our health from other systems. And here's one example. So this has worked particularly well in Wales, where they've got a setup that allows those and permits those and enables those linkages between different sectors, allowing us, for example, to understand the impact on adolescent health and the poor health outcomes that come from school absence and exclusion, and understand how to develop policies that might improve that. We've started to catch up in England by building a resource that does that linkage in England as well, and the time is right to start using that resource that links health data and education data to do that at much larger scale in England and of relevance to people in England as well. But that resource that's been built has taken years to build, and it doesn't yet include data from general practices, so we won't learn to understand about the health outcomes that are relevant outside of hospital, which is the vast majority of health outcomes, of course. And then linking those data from research studies to data on health outcomes, also really important. So a couple of examples here of major trials where this has worked. So the recovery trial used centralized services to provide data on hospitalizations and data from death registries to provide data on deaths, to allow it to follow patients who'd been given different COVID treatments, randomized, of course, to work out which treatments worked and which didn't. But without having 50,000 participants, you can't bring them all back to clinic or phone them up very easily to find out what the outcomes are. You need to do this through linking large-scale data sets together. They exist. How would we possibly conceive of doing it another way, provided we can do it safely and securely, and that has happened. And the NHS Gallery trial is another good example of where the centralised service holding details on patients securely within NHS England through NHS DigiTrials enabled millions of invitations to be sent to people who were eligible to take part in this trial of cancer screening and to recruit a very large number of participants, which was appropriate for a trial like this, and that trial is still ongoing. And then another research example based on UK Biobank, and there are thousands of these from UK Biobank, so I've chosen just one, because I think it illustrates nicely the linkage of data from different sources. So firstly, UK Biobank collected data on a large subset of its middle-aged participants from accelerometers on their physical activity, measured objectively over a period of time. And then through the linkages that Biobank has been able to make to healthcare data, mainly from hospitals and death registries so far, it was possible to follow those individuals over time and study the relationship between those objectively measured physical activity data and later life health outcomes, in this case, cardiovascular outcomes. So showing perhaps some results that are not entirely surprising, that compared with less active people, most active people are better protected against stroke and heart attack. But actually, importantly, with these objective measures from accelerometers, derived through this research study, the UK Biobank, linked to healthcare outcomes from the health service, it was possible to demonstrate that this protective effect is much bigger than we actually had thought through questionnaire data, which tend to underestimate these protective effects. So that's just one example of the many from UK Biobank that shows the power of linkage. Again, though, not being able to link to general practice data means that not all the events of importance will be being picked up. So for stroke and heart attack, it doesn't matter quite so much, because most of those patients who have stroke and heart attack will end up admitted to hospital. But the milder strokes, which actually can lead to significant disability, which is about a third of all of them, won't necessarily and are unlikely to be associated with a hospital admission. Those will be missing from this research. So there's an opportunity to actually make our studies and our analyses far less biased by integrating all the sources that are important to any particular question. So those are some really good news stories. There are many sources of data that can be used to save and improve people's lives, and they show how we already are doing this sort of thing well and safely to benefit people. But actually, these are very much and far too often the exceptions rather than business as usual. There is still great complexity, there's friction, and there are gaps in the system which really need to be rectified. So in the course of this review, we spoke to hundreds of individuals and hundreds of people representing hundreds of organisations across the NHS, academia, government, very importantly, patients and members of the public, and indeed organisations that represent them. And we got a sense of two types of priorities. the priorities that people feel are missing from our system in terms of the data that are accessible and available, linked to other data sources, to allow us to generate these types of benefits. I've shown you some examples of. And then the things in the system that need to be improved to help us streamline and standardize and do this better and more rapidly to generate benefits that people rightly deserve to see coming from these data. So in terms of data priorities, there's no question that the top priority again and again from almost all stakeholders was for a better national system for data from general practices. So we know that the data generated in general practice is amongst the most important and valuable in this whole ecosystem because it's the first point of care where patients mostly get a lot of their care. It's not the only place, it's not the only data set, and its value comes when it's linked to other data sources, but it's so often been missing from many of these studies and interrogations, and I think we owe it to patients and also to general practitioners to make sure that their part of the ecosystem is properly represented in these types of analysis. There are many other sources of data, and you can see them on the slide, that people called out as not being optimized, and I've gone into quite a lot of detail in the review about these and other sources. Maybe I should just alight on one, screening data. So this was something I didn't know before I started the review. I knew a few things, but I didn't know everything. And I discovered we have 11 screening programs, actually very similar screening programs across each of the 4 nations of the UK. But I also discovered from talking to people that whilst those programs generate data about the people who are being screened and who turns up and who gets invited and who doesn't turn up, so we know that information, what is incredibly difficult to do, hardly ever happens, and when it has happened, has taken years, is linking the data from the screening programs to the data on the outcomes of all those people who are screened to find out who is actually developing breast cancer or colon cancer, who is dying from breast cancer or colon cancer and others, to help us understand how we can improve our screening programs in the future. So without creating those linkages between the different data sources, we don't actually have an opportunity to work out whether our screening programs are doing what they should be doing. And I would say we owe it to patients, to the public, and to society to be doing that and to be having it as part of our routine activity. In terms of system priorities, then there's clearly a need to maintain, enhance, and link these national data assets that already exist but are not sufficiently and in a streamlined enough way brought together in the way that I believe that they should be. We saw some great activity during COVID, though, and we saw great improvements happen, and we saw proof of principle, if you like, that as a nation we can do this well, safely and securely, and generate insights that are truly beneficial for society and help to inform a better health service and better public health. But that access to data, those systems for data that were set up to subserve the needs of COVID, are absolutely the same systems that we need to address all the other pandemics across society: cancer, cardiovascular disease, diabetes, arthritis, mental health problems, the same systems, and yet we don't yet have the appropriate permissions in place to allow us to do that. It's not going to be that difficult actually to sort it out, but there has been some difficulty in moving that system beyond COVID. There's been a tendency for us to slip backwards into how things were prior to the pandemic, and this is really just letting people down. So the linkage is really important. I think I've illustrated why linking different data sets together is important. They're not so useful in isolation. We know that researchers and government analysts and many others besides, to do their jobs, which are for the benefit of all of us, have to often wait months or even sometimes years to access the data that they need, the various components of the data that they need to be able to interrogate it in the right way. So we need to streamline and standardize our governance, access and data processes so that that can be something that is done in weeks or even in real time when necessary, and it surely is for some purposes. And that involves reducing that complexity that Vin alluded to and that my report goes into in some depth. So it's not just complexity of many different organisations making up the NHS, but the many different computer systems that subserve the needs of our general practices, our hospitals and beyond, that don't talk to each other optimally at the moment, and there are certainly ways in which that could be improved. We also need to be able to, at times, move data between secure settings. And a really good example is the case of UK Biobank, which has the permission from each of its participants to hold data, not only that it's collected from its participants, but also that the health service and other administrative settings have collected about the patients, and to move it into the UK Biobank secure setting so that can allow that type of research to continue in the right way. Crucially, and I don't think this point can be emphasised enough, and it was brought up by both Chris and Vin, we need to do all of this in conversation with, in discussion with, and involving and empowering patients and members of the public, and indeed in conversation with and generating key links with members of the health profession as well. So it's only by involving patients and the public in an ongoing way that we can possibly do this. We need to be transparent. I would argue that it's really difficult to be transparent when there's a very complex system. So a good argument for decomplexifying our system iteratively over time is that it will become much easier to have those conversations and discussions and to involve patients and public at the heart of the decision making about what makes a good analysis, what makes a good result, what are the key big questions that need to be asked. We know we need better capacity in the system, but some of that capacity is in the wrong places and needs to be moved into the right places, so it's not all about new people and better training, but it is to some extent. We clearly need joint leadership and strategy. We heard that over and over again. And there's a need for long-term planning and investment rather than short-term investment that doesn't take us very far in a very short period of time. So a lot of this is starting to happen. As Vin said, these conversations have been going on for some time. We know that health data is used safely every day to improve people's lives. We know from talking to people back over 10, 15 years or so that overwhelmingly they support the use of their health data to benefit not only themselves but also others, provided the right safeguards are in place. There are many sources of data. Great insights come from linking them together. You've heard about the obstacles and delays and our complex and inefficient data systems. And so essentially, all this leads up to the first recommendation of my report, which is that we really need to recognise the UK's health data as part of our critical national infrastructure. So coming to the recommendations, of which there are 5 broad ones and quite a lot of detail beneath them, some of them, a coordinated strategy across major government and other public bodies, pointing in the same direction as we saw happen during COVID, to bring together and recognise health data as part of our critical national infrastructure. And the second important recommendation that Vin alluded to is that really the only way this can really possibly happen is to have a national health data service, a national entity that can drive this forward with senior accountable leadership. Doesn't necessarily need to be an entirely new body. We need to avoid what Andrew Morris calls initiative-itis, just setting up lots of new things. That adds complexity. So some of this could happen within existing structures, but it needs to be given the oomph of senior accountable leadership, needs to have a ring-fenced budget. With a single national health data access system, with streamlined and standardised data governance and access measures with performance metrics that hold it accountable for how quickly it is or is not doing what it should be doing, bringing those wait times down from years and months to weeks and days where appropriate. And I've focused as well on some of the key data assets that need to be focused on through that, so there needs to be some prioritisation. All of this needs to be underpinned by ongoing coordinated engagement with patients, the public, health professionals, and others. And that doesn't happen once. It's a repeated and ongoing exercise. It's a relationship, and it will get better over time, provided we see it in that light. And then some slightly more technical recommendations on the surface, but the fourth and fifth, which are really about how we need UK-wide approaches to help us link this up across the UK. So the first is around a UK-wide approach that needs to be led, I would say, through the Departments of Health and Social Care across the four nations in partnership with the ONS and the UK Statistics Authority, to create data access processes and proportionate data governance that are similar across the four nations, that are recognisably doing things in the right way. And alongside that, a UK-wide system for standards and accreditation for these secure data environments that we now see being developed, where it's really important that we understand what a secure data environment really is. What it says on the tin is what's inside the tin. And again, I've suggested that the UK Statistics Authority, in partnership with Health and Social Care departments, would be the right sort of organisation to oversee this. Thank you very much.
Thank you, Cathie, for such a clear and comprehensive presentation. We're going to move to a panel session now. We've got a great panel, and I'd like to welcome up to the sofa Dr. Beth Thompson, who is the Chief Strategy Officer at the Wellcome Trust, Nicola Hamilton, who is the Head of Understanding Patient Data, and Professor James Leaper, who is Associate Medical Director at the British Heart Foundation and Professor of Molecular Medicine at the University of Glasgow. We do have a couple of roving mics, but we're also using Slido, and the event is being live streamed, so you will be able to, for those of you not in the room, submit questions, and we'll do our best to get through as many as possible. So panellists, do come to the sofa.
Come and sit next to me.
Yeah, you do.
Thank you.
Welcome, everyone. Cathie, thank you. I might, as we wait for questions to come in, first turn to Nicola, if I may. Nicola, it would be fantastic to get, I suppose, a reflection on what Cathie has presented, particularly where you think the patient and the public and patients are at the moment. We have been round this circle a few times. As Cathie says, it's absolutely critical that this feels like a conversation and a relationship. But your sense of where the public is now and the opportunity that the review presents.
So I think the review presents a really positive picture of all the opportunities that there are to make this a much more cohesive, simplified system. And I think that's what a lot of patients and the members of the public want. At the moment, it's really difficult to be able to find out where your data is being used, why it's being used, what's happened as a result of that data use, and you would probably have to talk to a few hundred organisations to figure that out, which isn't very transparent and doesn't help build public trust. We know from quite a lot of studies recently looking into public attitudes that there is generally that trust there, but even small issues, whether it's within the health sector or even in the wider public sector, misuses of data or issues that end up in the press can really damage that trust. So as well as the vision, we really need to make sure that we are ensuring that transparency and public engagement is a constant process.
Thank you. Turning to Beth, Wellcome Trust has been a long-term advocate, had a long-term interest in a better data environment. Your initial reactions and reflections on the report?
I think Cathie here has presented such a compelling view of why we need to shift this crucial issue, but also how we can start to do it. And I'm really struck to see everything together in one place, really for the first time, that we do need to take the big and the bold action, as Cathie said. So it's very easy in this space and tempting, I think, to tinker around the edges. But actually, what we need is to, I think, take the political momentum that we have through the new government's health and growth mission and really pair that with this, technical and really thoughtful approach to what must happen. And so I'd love to see from here the shared sense of strategy that Cathie talks about. I think we have to bring this combined vision, the big picture change that needs to be driven through. And that does need the academics, it does need industry, it does need the NHS to work together to solve that problem in a really coherent way. And that means talking to each other and really thrashing through some of the things that can be more difficult. But remembering at the heart that this is about patients, it is about the difference that we can make to their health, but also really how do we capitalise on this crown jewel for the UK when we're not at the moment making the best of it for our health or for our wealth. And I think there is now a political imperative that we act.
Thank you. And James, your reflections, I think particularly I reflect in heart disease and cardiovascular disease. We've seen fantastic progress in insight through linked data. Your view?
Well, first of all, to congratulate Cathie on, what a fantastic report. And I think it's extremely timely. I think that we were very proud that Cathie was the first director of the BHF Data Science Centre. And that really, through COVID times, exemplified actually the power of linking data and the benefit for patients and the public of doing this. I think that we're very keen to focus on the prize here. There's an enormous prize, and the UK is in a fantastically strong position to capitalise on that. That's not to underestimate the challenges, and I think you've described the challenges, but you've also described the solutions in your report. So I think this provides a really exciting framework for all of us going forward to work together with patients and the public, bring them on this journey, because I think if we can deliver the prize, we will be in so much a better situation.
Thank you. I'm going to turn to Slido and then come out to the room. So the most popular question so far, I'll direct to you, Cathie. Do you think any radical legislative change is needed, or can all these goals be achieved via system change and a little reorganisation?
So I think, the answer is both. I think that, so I'm not a lawyer, and I don't want to kind of enter into detailed conversations about minutiae of the law. But from talking to many people about this, there are clearly potentially some legislative changes that would be facilitatory in this environment. So probably the most important kind of bit of legislation that we saw work really well during the pandemic was the use of the control of patient information notices, which is a Secretary of State direction system, which allowed data to enable data to be used and made it mandatory for data to be provided in the right way in safe, secure settings to be used for the benefit of the COVID pandemic. I think the same mechanism could potentially be used more broadly to help us address all these other pandemics as well. So, and I think it was particularly helpful. It was one of the helpful mechanisms for enabling general practice data to be linked to other data sets at scale for the first time. We saw how well it worked during COVID, and there's probably a need to review and update the COPI regulations so that they can be more readily applied for today's circumstances. And Vin might want to speak to that more because I know it's something he's thought about a great deal. And then there's another piece of legislation, the Digital Economy Act, which Ian might want to speak about as well, which has been very helpful in providing a permissive legal gateway for the linkage of data from different sectors of government to allow those data sets to be used in a way that's helpful for generating all sorts of intelligence about society and to help us run society better. But health and social care data were excluded from the DEA when it was drawn up back in 2017, I think, or when it was enacted in 2017. And it's definitely worth revisiting that to see whether including health and social care data would help. I would say, though, that any legislative fixes or changes need to be very carefully thought about before enacted, because sometimes by bringing in changes we simply add more complexity, and sometimes the existing legislature, if it's appropriately thought through and interpreted correctly, can be used much better than we do currently. And I think that was true of the COPI notices, and there are already things that we can do with existing legislation that we're not doing that would be helpful. There was a second part to your question, but I can't recall what it was.
And so this is moving about an awful lot. So,
radical legislation, but something else.
well, or can we, through system reorganisation,
Yeah.
achieve very similar aims?
Yeah, so, well, I certainly think there is significant low-hanging fruit, if I can call it that. So, and we've seen that. So, you know, what happened during COVID was we saw many organisations, major national public bodies, research funders, the NHS, and researchers and analysts themselves all pointing, for the first time in my life actually, in roughly the same direction and working exceptionally well together. And I think we've lost some of that. Now, maybe it's naive to suggest that we can recreate it when we're talking about many different health conditions, but I think we should be doing absolutely everything we can to use those mechanisms we saw work well, continue to drive this forward. If we only use the infrastructures that we now have in place and the data sets that are now in place in secure settings linked together well for beyond COVID questions, if we only did that one thing, that would be a massive and significant advance. There are many other things we can do, but I would say that would be a really major piece of low-hanging fruit.
Lovely. Thank you. And there's another very popular question, probably directed mainly to you again, Cathie. What practical steps can health data custodians take to encourage funders to take a cohesive approach to supporting a single infrastructure rather than new fragmented initiatives?
So the approach was by what can health data custodians do about that? Well, I mean, maybe I can turn that around a little bit into how I think there's a huge opportunity for funders to continue to work jointly together. And James and I were talking about this earlier on. So particularly major charities who work very closely with patients and the public, to make the case through those channels, but also to unite in their funding efforts and to coalesce around this notion of a cohesive national infrastructure. So for those sources of funding, that's brilliant. I would say it's true of sources of funding that come directly from government as well. The more that they can be aligned, the more we will make progress in the same direction. I think in terms of data holders, data custodians, data guardians, are people who are responsible for data sets or data assets. They need to be asking themselves the right questions, which I would say are, how can these data that I'm the guardian of, that I'm looking after, how can they be used as widely as possible to generate benefit for patients and public and across society? How can they be used to link to other sources of data? How can I work with other data custodians to make sure that we're doing things in the way that Chris alluded to, that's creating an infrastructure that can be used repeatedly for multiple different purposes by different organisations, of course with the right safety and security measures in place. And instead, I think quite often the question that's primary in the minds of data custodians is, how can I make sure that the data are protected and kept secure, and that I'm protecting my own and my organisation's liability? Of course those are important, but if that's the only question you ask, then you just lock the data up in a chest, put a padlock on it and stick a great big tiger on the top and don't let anyone near it. And so you've got to ask the question in the right context. The safety and security, sure, they are absolutely important, but they have to be in the context of using the data. If we don't use the data, we won't get anything out of it.
Wonderful, thank you. And then perhaps a final question, and then I'll come out to the room from Slido. Had a question about GP records and integrating primary care data. It would be fantastic to get people's perspectives on this. I mean, some of my work in health charities, I think there was an assumption there was perhaps more linkage happening than is the case. Nicola, to you first, what's your sense of where the public and patients are on this issue?
So we've got a public attitudes programme about GP data specifically underway at the moment, which hasn't concluded yet, so I can't give any results. And I know it's also being explored by the NHS England and Department for Health and Social Care public deliberation programme. Again, very live. Last weekend they were discussing it, and this weekend they will be finishing off their discussions about it. Broadly, I think that there are assumptions that it's being used and linked more than it currently is, but there is difficulty in that a lot of people do see that data as particularly sensitive or different. We're trying to figure out the extent to which people feel that that's different to other health data that they have. So it's a difficult one. I think we might be able to move and make some progress in that space, but I'd be very wary of kind of centralising it and just moving to a big centralised system very quickly. As we know, we've struggled with that in the past. There have been a lot of public conversations about existing systems that are in place, like Open Safely, that seem to be very well respected with members of the public, despite the fact that, you know, it's millions of people's records. So continue to learn from those different examples that are underway at the moment.
Thank you. Beth?
I think this is one of these key areas where we have to look at the opportunity cost of not acting and not doing better. And I think Cathie's really clearly painted this huge hole, actually, in the data that we're able to use. And we do completely have to have those good conversations with the public, really robust conversations, and with GPs themselves to make sure that we are doing this in a trustworthy way and in a secure way. But it's somewhere that we can't let these data islands or silos or that kind of protectionism for the data get in the way of what is possible, because it is the biggest gap that we're seeing at the moment. And I think, honestly, it's inexcusable if we don't find a way to use that to benefit people's health more broadly.
Thank you. And James?
I agree with what's been said, but I would add, I think there's a role here for the medical research charities to be advocates for this data. We are independent, we are trusted voices with the public and patients, and I think that we can be part of the conversation to bring patients and public along and illustrate actually the benefits to them of doing this and the safety that's built into it.
Thank you. Questions in the room? If you would please keep them brief if you can, and we'll take 3 at a time, and if you could just introduce yourself. Gentleman here.
Thank you very much. Henry Lee from Tony Blair Institute. We are really grateful for the opportunity to contribute towards the National Data Service recommendation that you have, Cathie. So question, we really strongly agree with your proposals. Question here is that from our work on the National Data Trust, we feel that it would be indispensable for private investment to be a key part of any resultant organizational form that this National Data Service holds. And we really agree with your point that we need to decomplex the system a little bit and not just keep generate new sort of like institutions. So given that, where do you see the opportunities are in terms of coming up with structures that can hold additional private investment for initiative like that? Thank you.
Thank you. And then just in the second row here.
Hi, I'm Yvonne Adebola from Use My Data. I'm wondering what all of you think about, 1, the role of industry in helping with this, 2, the role of partnership organisations such as Our Future Health, and maybe even the role of primary schools.
Fantastic, thank you. And I think there was a question. Lovely, thanks.
Hello, I'm Camilla Hawthorne. I'm Chair of the Royal College of GPs, so I just wanted to respond to the question that was posed about general practice data. I would say that GPs are fully aware of the value of the data that they are currently controlling. There's no doubt about that. The problem has been the indemnity of releasing that data surrounding that and not having implicit trust in the organisations to which they would release the data to. And that is where we need to really work on making sure that people feel comfortable that they can release the data, maybe be relieved of the indemnity. I'm understanding that there is going to be a task force, and I would very much like to volunteer the RCGP to be on that task force, please.
Thank you. That's 2 questions and an offer, I think. But the questions around particularly private investment and industry and partnerships more broadly. Beth, do you want to start?
I think, as I touched on earlier, this has to be the solution we will only find if we bring together the different users. So that has to be industry as well as academics and as well as the NHS. So I think that is an absolutely critical part of finding the solution and creating a mechanism to do that in a holistic way. We actually have a very fragmented advisory landscape at the moment in terms of the inputs to the thinking. So let's make sure that the strategy is informed by a broad conversation, but also a single conversation that brings those threads together. So I really agree with that. I think we have to look really carefully at the mechanisms for National Health Data Service. It's an absolutely critical part of this, that we find a pragmatic way to make that work, but we have to do it in a way that is trustworthy. And I think, as Cathie said, it has to be nationally and public infrastructure and thought of in that way. So I think there we have to look at how do we balance the trustworthiness and how do we actually make the case for the public investment this needs, because ultimately it's a part of its public services, public infrastructure. So I wouldn't want to jump to a solution about how we fund it without really thinking through what the public options are first.
Thank you. And Nicola, you might want to comment on this.
Yeah, I was just going to pick up on the point about partnerships and schools as well. I think that's particularly important. We know that people's health literacy and data literacy isn't particularly good generally, and there is an opportunity to influence that from a young age. I know a brilliant ex-GP who's doing work in kind of the Sheffield area, who is going into schools and having these conversations about health records, what they are, what they look like, what's in them. And that would set us up much better for when we have these conversations later down the line about should we do this or should we do that. And at the moment, people's frames of reference tend to be either their personal experience of the health service or what they've seen in the media, and we know that that's always quite tricky. So building up that knowledge from a young age and working with organisations locally, regionally, that are important to people, and that can also be organisations in the civil society space that are maybe more campaigning on data rights and challenging government, the civil service, the NHS as well, to make these ideas and programmes the best they possibly could, and not being afraid of that challenge is really important.
Thank you.
Just on the partnerships and the involvement of the industry and commercial partners, I think that there's enormous innovation that's going on in the commercial space, and exponential kind of productivity in terms of data science and the way these things can be done. And I think to cut ourselves off from that would be foolish. But I think that we need to it needs to be very carefully regulated, and it needs to be transparent, so that we can tell the public and patients exactly what's happening and exactly which partner is involved in which areas. So I think Cathie calls out for simplification and transparency in the regulatory process. I think that would be essential if we are to bring the public along and convince them that actually having commercial partners involved is important. So I think that's where we would sit on that. And I would just say about schools, I think that's a brilliant idea. And I think that actually introducing as early as possible to people the idea about how data is used, how data is used in health and management of health, I think would be great.
Yeah, I mean, just so really useful and very helpful discussion. Just one maybe additional point to make, which is that if we just continue to think that patients and public are at the heart of this, I think it helps us to get this right. Mm-hmm. So everything we do should be in the interest of improving the health of patients and society at large, and improving the public's health. Because huge benefits to our economy will come simply from improving the health and the well-being of the population at large by using our data well. And if we hold on to that, then it becomes much easier to have the conversations about what type of inward investment from the commercial sector would be attractive for us. And if we make sure that patients and public and health professionals, where appropriate, are involved in those conversations and discussions about setting the agenda, then we're far more likely to get this right and not to put people off by bringing up the things that they sometimes find a little uncomfortable. So people making a profit out of data is often uncomfortable to patients and members of the public. We have to keep their benefit right at the centre of the frame, and then we've got a really much better chance of doing this really well.
Thank you. A very brief comment on the partnerships and schools. So in my last role running the National Respiratory Charity, we used to go into schools to measure levels of air pollution and then talk children through it and what that meant for their health. So there's something really interesting about literacy in this area from a young age, because it can seem very complex and a bit alien and something over here. It can be fun if it's kind of couched in the right way. Thank you for the question. Lots more hands in the room. Andrew, first of all.
So Andrew Morris, Director of Health Data Research UK. Firstly, congratulations on a great report. I know a lot of it was written in the wee small hours of the morning. So my question is around skills and talent, because to deliver this, we will need interdisciplinarity across physical, computational, social sciences, law, and ethics. For example, in the Royal Society, they presented a report last year on privacy-enhancing technology to enable data governance and collaborative analysis. So what are the implications of the report for the skills and talent agenda within the NHS?
Thank you. Are there other hands in the room? Yes.
Hi, I'm Olivia Valuenta, Senior Data Policy Manager at Smart Data Research UK. We fund data services, and I've been doing a lot of scoping work relating to the ethical and legal frameworks relating to smart data, which comes from digital data sources, shopping transactions, environmental sensor data. And there seems to be lots of challenges in that space. I mean, it's super helpful to have this layout of the health data landscape and legislation and the challenges there. And I think with regards to our data services and others, there seems to be an opportunity to more professionalize the way in which legal frameworks are approached and ethical frameworks are approached, and actually support the academic sector in that space. Really helpful as well to see the consent commentary in your report and the discussion of consent and the recommendation to reduce bias in smart data sources. I was interested to see that recommendation, and I just wonder if anyone on the panel has thoughts about bias reduction in those data sources and what you'd like to see move forwards in the health data space.
Thank you. And I think, question over here.
Hello, thank you. It's Petra Ankowska from the Royal College of Radiologists. I want to go back to your point about patients and public being at the heart of this. And I have a particular question about how you think we might be able to improve the sort of digital connectivity of our public, particularly the elderly population, not all of whom are necessarily digitally connected when it comes to collecting data, particularly from my perspective in relation to things like late radiation effects. We've got a great repository of data on acute radiation effects from the National Radiotherapy Dataset, but once people complete their treatment, the collection of data regarding late radiation effects is very hit and miss depending on which part of the UK you happen to be on. And that clearly is related to having that connection with patients often long after they might have been discharged, because we're talking about effects that may occur 10 or 20 years down the line.
Fantastic, thank you. Well, three quite different questions. Cathie, do you want to start on skills and talent, but you take the other questions as well?
Yeah. So capacity is an issue that I raised, and there are two areas of capacity that came up repeatedly in conversations about how to make this ecosystem better. And One was actually around the capacity within the decision makers system. So, people who understand information governance, the sense that we need more of them. Now, I think we have to be careful about that because we don't need more decision-making nodes. We actually have far too many decision-making nodes, and only one of those has to go in a different direction from all the others, and we get nowhere. But we clearly need people who are well-informed and can interpret legislation in a unified and coherent and coordinated way, and arguably that needs better advice and guidance throughout the system. So I think there's an education and capacity need there. And the second, which I think is more the one you're alluding to, Andrew, is the capacity in the system around the management and curation and analysis of data using the very best methods that are available. And sometimes that isn't always about the whizziest or the most exciting sounding or the ones that have wham-bam slides associated with them. It's actually about really important fundamentals about making sure that the data are well looked after, well and appropriately described so that they can be understood by the users. So what we call metadata, or really good data dictionaries, and well curated. And the curation of data to make it fit for different types of purposes is something that we do as far as possible once and then use repeatedly. So this is something, of course, that Ben Goldacre talked about a great deal in his review and very eloquently. And I think now the vernacular of reproducible analytic pipelines is now in common parlance. It's very frequently used. I'm not yet convinced that everybody who uses that terminology really understands exactly what it means. And so I think ensuring that we understand what the need is and that we celebrate the people who do that work. They are fundamental and important. And certainly across academia, the data curators and the software developers who enable that have been undervalued and under-celebrated systematically for far, far too long. And I know that Ben and certainly I and many others feel very strongly about this and have been trying to make the case that this needs to change because they are going to be the people who are absolutely essential to making this happen.
Thank you. Beth?
To briefly pick up on the bias point, but to zoom out from smart data to data more broadly, for this to really benefit patients and to benefit everyone, we need the data to reflect and represent everyone. And I think this is a really crucial benefit that the UK has actually globally, that we have a hugely diverse population and we need to see that reflected back in the data. So for me, it's another really compelling reason that we have to get better at joining this up and pooling the different data that we have. So both we can unlock that benefit for the UK, but really importantly that we can make sure that every single patient has other patients who look like them within that data set. So I think your point on bias and making sure that that applies through that we reduce that throughout the whole system is absolutely crucial.
And Nicola, I wonder if you want to build on that, and partly in relation to the question about those that may not be so digitally enabled, but also perhaps different levels of trust in different parts of the population, and if we're to make really good progress, we need to work, with the full population.
Yeah, so I suppose making a lot of our NHS services digital helps a good chunk of our population, but if too many things move in that direction without additional ways of getting in touch with or communicating with the NHS, you do leave some people behind. And I don't think that necessarily means everyone needs to be trained on how to use particular technology or have that connection in their home. I think I saw something recently about training people up in local libraries on the NHS app and people being able to go there and get the help they need. And, because otherwise, like, who do you go to? I mean, at your GP surgery or at your hospital, does anyone have the capacity to sit there and help you with that sort of technology and show you what's there? Like, probably not. So thinking about those wider community structures that people can make use of is really important. In relation to bias, I suppose there's been quite a lot of research that looks into levels of trust from different communities and differentiating it by different protected characteristics. And we know that there are some groups who tend to be a bit more mistrusting of the government or the NHS than others, and particularly what's being done with their data, and that's very historical and community-based and takes a long time to change. So particular types of public engagement or messages or communications efforts that work with some people won't work with everyone. So it's about thinking a bit more about how we engage with people in different ways and not expecting one thing to work for everyone.
Thank you.
I was just going to add to that, wearable technology for health is on the rise, but it's unevenly distributed. And what we don't want to do through incorporating that data is actually to exaggerate inequalities that we know are already there. So I think creative thinking about actually how people access digital data and contribute to their digital data is really important. And I think that, engaging with the public, getting them to understand the benefits of the health data, how they can interact with it, and what it's going to be used for will be an important thing to do, in addition to the educational piece that you've talked about.
Thank you. We've got lots and lots of questions on Slido, so I will try to get through a few of them. Cathie, if the UK health data systems were designated as critical national infrastructure, would this strengthen cybersecurity standards, e.g. mandated oversight from the National Cybersecurity Centre? So part one, and just to broaden that, I really like the phrase national critical infrastructure because it gives a status to this work and this endeavour. So what are the other benefits that might accrue by sort of lifting up and really valuing the data we have?
So I'm going to make an admission here. When I wrote the term critical national infrastructure in the report, I wasn't really thinking about the formal government definition of critical national infrastructure. Give me a moment. I was thinking about that from my point of view of this matters so much. These are the words, I can't think of other words that I would naturally describe it. I then had a conversation with Vin and Chris and others who pointed out there is a formal definition in government parlance for critical national infrastructure, which I looked at, and it's around things that we need to have in place for the safety and security of the population and the economic stability and benefit. And I thought, well, that is all of those things are exactly what I'm talking about. So actually, I think the formal definition of critical national infrastructure, from my perspective as a layperson in government parlance, is met. And moreover, our healthcare system is part of a critical national infrastructure, or components of it are. So I think it's not a big step, actually, to make that point about the health data part, which is an essential component. If it doesn't work, then the rest will not be properly informed. And so, yes, I agree with that point. It does lift it then to a level, whether it's an informal term or whether it's formally adopted, it lifts it to that level where it does get the due attention that it needs, because it's very much a critical part of our society's needs.
Lovely, thank you. A question about measurement. So somebody has referenced Chris Whitty's comment about the gap widening, and Cathie, you talked about COVID permissions and almost sort of losing ground from where we were. So it would be fantastic to give us a sense, and other panellists will have a view as well, perhaps from the public's perspective. How do we begin to measure progress in a way that feels tangible, in a way that feels understandable to people? What would you like to see over the coming years?
So, I think this needs to be properly discussed and worked out, and I haven't tried to lay out an entire recipe because it's not my position to dictate exactly how everybody should do their jobs. But it's clear to me that we don't have nearly enough simple measures of performance that are, we don't need very many actually, but we need some simple measures of performance that will tell us how well the systems around data access, timeliness of availability of data, through to the generation of insights and impact on policy. We have not a good way of measuring that life cycle. And there are some simple things that could be put in place to start with. So, length of time it takes from lodging an application through to through to gaining approval for that access, and then length of time from there to actually being able to work with the data and use it well. And these should be used, these types of measures should be used constructively. And actually one of the best systems I've seen do this well was UK Biobank. So obviously it's a tiny little part of this enormous system, although it's a very big and a hugely impressive study. But in terms of when UK Biobank as a research resource opened its doors, as it were, to access to the research community, it very quickly started to measure how quickly it was able to do that. And then it sort of examined the way it was measuring it and thought, are we measuring this in the right way? No, we're not taking into account the fact that sometimes there are decisions that go back to a researcher that then take ages for them to sort out, and then it comes back to us. So we need to measure it in a more informative way. I think if you start measuring these things and then you improve the way you measure them over time and start to set some realistic but ambitious targets. So, weights of years are clearly unacceptable. A lot of analyses just don't happen because the money's run out, the time's run out. Weights of months, not quite so bad and probably acceptable for some things. Others, we need weights of weeks, and others we need real-time data. So we need to set the right targets for the right purposes, and then do everything we can to move towards them.
Lovely, thank you. Beth, could I come to you, and then I might pose a final question to the panel before we end, but on this point around measurement.
I think Cathie's laid out a really pragmatic approach there, actually. It's easy to get bogged down in trying to find the perfect measures, and the perfect measures rarely exist, but actually having something to measure and to check your progress is a critical way that we know we're moving forward. So I really like this idea about you set them, but you treat them pragmatically and for what they are, and often as proxies rather than assuming that they are perfection in themselves, and to keep iterating them. And I actually think there's a broader lesson in that for how we approach this overall. I think we know there have been mistakes made in the past in producing some of this, but I think sometimes that fear of getting everything perfect holds us back from actually taking the action. So it does need to be done really thoughtfully and with in a very trustworthy way, but I think we have to stop that kind of the fear holding us back from what is possible.
Thank you. My final question is about momentum and what next, and how do we get moving on some of this, because I know lots of people in this room and watching the live stream will be fully on board, desperate to see movement and quickly, absolutely recognising, we need as a community to move as one, and that includes the patients and public. Maybe I'll come to you, Cathie, last, but from the other panellists, what are your ambitions over the next couple of years? What would you like to see done as a consequence of publication of the review? Nicola.
So I'm really looking forward to working on that recommendation around a national strategy for talking to members of the public and patients, and that needs to be across the UK as well. It needs to be done carefully so that we're not asking the same questions where we don't need to be asking the same questions, but filling evidence gaps that exist in how people feel and making sure that we're measuring any changes over time, and identifying specific questions. That is probably the main one for me, I think.
Thank you. James.
So I think around data and data access, so I think standardisation across the SDs so that researchers have an even picture of the data. I think access, timely access is really important. We see a lot of frustration with people getting access to the data. So I think that, simplifying that access. I think it would be great if we can link the 4 nations. There's a huge amount of disease burden outside of England, and we need to link that to get equity for all. And I think that the final thing, I think, is there's great innovation in data science going on, and approaches that one can use with health data. So whatever regulations put in place, there needs to be the flexibility that as we continue to innovate, that is allowed within the system and it doesn't create additional delays. But I think, a very exciting time.
Thank you. Beth?
I think we have to start seeing the use of health data for research as a necessity and not a luxury. And I think that's the crucial takeaway for me for all of this. And to make that progress towards a national health data service is going to require the sector to come together, to have a unified set of conversations and to really build that single strategy and a roadmap to action. And I think unless we start to join things up better, we'll get held up. So let's really take it upon all of ourselves, but to use the political imperative that we have to actually drive real progress on that National Health Data Service.
Cathie.
Yeah, just two things. So the first is to say that in terms of the absolutely fantastic resource that Understanding Patient Data have generated, we know from wonderful summaries on their website, which I referred to quite extensively in the review, that patients and the public in general, over the last 15 years or so, have expressed repeatedly about the same level of desire to ensure that their data and wider data are used for not only their own benefit, but also for the benefit of others. And consistently, at about 70, 80 or 90%. So that's a great deal more people who are in favour of this happening than we use to make many other decisions in society, where sometimes 51% or 49% is considered enough. So I think that's a really important point. The majority of people are behind this and have been behind this for a long time, and we owe it to them to make sure that this happens. The second point I would make is that I think this is very timely. You've heard from Vin, who spoke on his own and Lucy Chappell's behalf, from the point of view of the NHS and the Department of Health and Social Care, and I think this is highly likely to be true as well across the devolved nations. We have a new government. There's great momentum behind this. This review has been a process. There have been a lot of discussions going on. Things are already starting to happen, and I think it's on all of us in this room and beyond to make sure that that momentum is maintained by working together and collectively, and continue to point in the direction that we started to point during the pandemic and keep the momentum going, not for ourselves, not for our research outputs, not for our careers, but because that's what society needs.
Thank you very much. We have run out of time for the Q&A, and I'm sorry because there are lots of really excellent questions on Slido. I will share them all with Cathie and the other panellists, and they may come or give a view or certainly reflect on what else people have asked about. I won't attempt to summarise, but a couple of quick points. There is a point about partnership which I wanted to emphasise, and people really taking something from the review's publication and the event today, which is thinking about their part in making this a success and driving it forward, number one. Secondly, I think this ongoing conversation with the public and patients, which has come out a lot, is a really virtuous circle. So in a former life, I spent many years working in cancer, and just the insight and the improvement in patient care, for example, from occasionally linking screening data and showing people the impact of cancer screening, was then incredibly powerful to go out and engage people and talk to them about the benefits and sometimes the challenges as well, but to have a really honest conversation about the power of research, the power of interventions. It helps build that trust. So this idea of an ongoing relationship, not just single points of conversation, I think is really key. My final point, which I suppose has been implicit in some of the conversation, we've got a new government, we've got an ambitious programme for government. There's a lot that the government wants to do. And in that context, maintaining this as a priority over the next few years, again, requires a lot of time, effort, thought, work from all of us, because there's a really busy agenda, and the danger is it slightly slides down the priority list. So what can we all do to keep it high on the agenda? The most important thing I have to do as host is keep us to time, and we do have a really hard finish at 11. So finally, I want to say thank you and congratulations to Cathie on a wonderful report that is going to stand us in really good stead, and to invite Professor Ian Diamond to close us with a few words.
Colleagues, thank you very much. It's an enormous privilege to be here. I just want to start by thanking you, Sarah, for leading us this morning so brilliantly, as well as thanking the panellists and colleagues who've had so much to make this morning happen. I think it's a really important morning. I also want to thank Chris for ringing me up a while ago and saying, this is a good idea. And then it took us, I'm sure, less than a nanosecond to say this is a brilliant idea. And as soon as Chris said we could ask Cathie, I was like, oh my God, this is going to be brilliant. It has been brilliant, Cathie, and it's just so good. I don't want to say anything that has already been said. I do think that Cathie's presentation this morning, all of us have a responsibility to get it seen as widely as possible. I thought it was a call to action for everything that we've talked about. The one thing I would add is that we should not fixate on talking about health data. We should fixate on talking about the use cases and why health data are important. But more than that, for the last 50 years, I recognise now, I have been absolutely personally focused on the fact that data, properly used, can impact on the inequalities in our society. Can impact on the inequalities. And in a society that we're in at the moment, where between the highest decile of advantage and the lowest decile of advantage, healthy life expectancy, the differences are 14 years. I do believe very firmly that we have not just a responsibility, but a moral responsibility to use those data in a proper way to enact on that, frankly, unacceptable, in my way, level of inequality. And the bottom line is, if I go back 50 years to when I first used medical records in research, I spent much of the next 30 years saying, if only. You get a medical record, you think, if only I knew about the ethnicity, if only I knew about the income, if only. And of course, the only thing to do was to get your clipboard out and go running around asking. We can now do so much. We're in a position now that, frankly, we can do everything, almost everything, I've ever wanted to do in this arena, and I do believe we've got an absolutely moral responsibility to do that. But that's about health. It is about much more. What we've been talking about this morning is much more than health, I would submit. The government, absolutely brilliantly in my view, has named 5 missions that it really wants to go with. Health is one. The others, of course, growth, opportunity, safer streets, and net zero. In fact, Chris and I, isn't it great, Chris? We are wise owls. I've never been a wise owl before, but doing so with Chris is fantastic. And that's a senior analytic leadership team which has a responsibility of overseeing and looking at each of those 5 areas. And the first thing I would just say is yes, health is important and everything we've talked about today matters, but you cannot, I would submit, make progress on opportunity, safer streets, net zero or growth without health data, without bringing health data into the story. Let me give you an example. In the period since the pandemic, 500,000 people in our country over 50 have left the labour force, 500,000. In addition, we are seeing small but measurable spikes in the number of 18 to 24-year-olds leaving the labour force. There are many reasons, but the main reason of this inactivity is ill health. Ill health. Now, my colleagues get very nervous with what I'm about to say. Very roughly, okay, very roughly, 100,000 people in the labour force equals 0.1 on GDP. Get those 500,000 back into the labour force, you've got 0.5 on GDP. I think we'd take it now. But the question is, what can we do to make that happen? How do we do that? And linked data can really help us to understand that. We've just done some work at the Office for National Statistics looking at bariatric surgery, linking and building a natural experiment, linking people who've had bariatric surgery, those haven't, and what happens then to income and activity in the labour force, so linking with HMRC data on income. And the bottom line is that it actually has a massive positive impact on activity of the labour force. Massive positive impact, really good news. Exactly the same with talking therapies. These are issues that we can look at the health issues, we can understand the health issues, and we can then measure and understand how they'll impact on growth. I was so delighted when Andrew Morris rang me up recently and said he's got a group of people who really want to look at inactivity and the labour force impact and the health relations and understand the causes. And oh my God, there is so much we can do, and we'll be working to make that happen. Chris asked me to keep my remarks this morning down below 4 hours. And I'm really going to do so, I promise, but without hesitation or repetition. So I just wanted to push on and say, look, this is unbelievably super important. But there is another initiative that the government has put in that I think is super important here, and that's the National Data Library. And I do think there is a real opportunity for us in this community to link with us National Statistics, the Department of Science, Innovation and Technology to really make this National Data Library a real success, which will enable us all to be able to link these data together, to ask the question, what are data? You know, to address born digital data, survey data, administrative data, all bringing them together to answer some of the most important questions our society needs. And remember, when you walk out there this morning into the streets anywhere, every one of your fellow citizens that you pass can have their lives improved by using these data in a proper way. And I know that might sound a little bit pompous, but it's actually true. And it's not a bad way to finish. Cathie, you've changed everybody in our country's lives. Thank you.